So we have time dedicated to a panel discussion, and we'll take some questions from the audience. So Bob and Laura and Catherine, if you could come up. And please don't be shy. I know it's... And I will also introduce Jean Lloyd, fantastic addition to the panel, in the center of the panel here. And Jean was the national nutritionist for the U.S. Administration on Aging, and is very well known in this area on this topic, and thought she would be a great addition to the panel. So thank you, Jean. And for the others, any questions? We have microphones, please. If you can use microphones, that probably helps save Kyra from too many jobs around the room. Oh.
I want to know if people on the panel talking about different programs that might be relevant for nutrition are aware of the CMMI program coming up on chronic diseases, and the 7 states that will have pilot programs for Medicare to look at how Medicare can reduce chronic care management, and if you see nutrition as part of that.
Is this on? Yes. Well, I'm not really quite sure of the program that you're talking about, but I definitely see nutrition as a way of decreasing chronic disease management, especially in terms of some of the chronic diseases like heart failure, diabetes, COPD, things of that nature.
I've heard something about it a little bit. There's some discussion about a future model of care transition program coming out of CMMI in that area, and I suspect that may be a little bit of what you're talking about, and I guarantee you that we're going to be pushing hard to make sure nutrition is covered, because those first rounds of grants were not as robust in the nutrition area they should have been, and the relationship has grown so much stronger in people's minds now that we need to do more effective work inside CMS on that one, so thank you for raising that.
I think that's a good point that you raised, because I think one of the missing things in this whole group, et cetera, is that connection with nutrition and health and transition care, because most of the grants that were funded for transition care, as you notice, did not include nutrition because it was not a part of the evidence-based models that were based on. Mm-hmm. Some of the programs then added a supplementary services, and the 2 supplementary services that were added were home-delivered meals and transportation. As you notice, transportation seems to be an issue throughout a number of this. So again, I don't know if it's going to be a part of those, but it is definitely needed, and in many communities was found to be lacking.
I was going to comment on that. Maybe, I don't know who the reviewers are for those grants, but sometimes we need to advocate to have strong reviewers that have a good nutrition background to get on some of those panels, and that could be a way.
And yes, the reviewers did not have strong backgrounds.
Jean, since the funding for the Older Americans Act relative to the number of older Americans in our country is decreasing, and actually the number of older Americans served both in community programs and at home is fewer today than it was a number of years ago. What awareness are you seeing in the states where they're using some of their other monies, like Medicare and Medicaid monies, to pay for providing people with more than 5 meals a week, which we all consider the 5 meals a week to be kind of a starvation diet?
Well, a couple of things. To back up your statement about less funding. Funding in 1990 was about $25 per capita. It's now less than 12. So funding since 1990 has gone down. Again, it's a discretionary program. It is not an entitlement program. whatever. And feds only provide about 30% of the funding for home-delivered meals and about 44% of the funding for congregate meals. So the program has always accessed other services. Under Medicaid waiver programs, about one of the slides said 46 states include something. It's variable about what they include because Medicaid waiver programs, which are designed to provide services to people who are nursing home level of care, but keep them out of nursing homes in their homes. For those programs, meals may or may not, it's an optional service, it is not a required service. And some states say, first they have to be served under the Older Americans Act, and if there's not enough Older Americans Act money, then we'll serve them under the Medicaid waiver. Given the funding for Older Americans Act, it's not real easy. The other issue is trying to get funding from other private sources and other public sources. There are some grants out there trying to help the Aging Services Network to have insurance companies, managed care, and those organizations pay for services such as meals and nutrition education. Those grants are just out there now. I don't know what will result.
You know, a repeated theme all day has been the value of community participatory programs to have any opportunity for success. And I was really struck by the food sovereignty program that was described. And I wonder if we can't learn from that program in terms of designing better community participating interventions, whether it's, you know, at a regional, racial, or ethnic, or community program. So I wondered if you might be able to share some of your other experiences with the food sovereignty movement that you think we might be able to learn from.
I guess Rona LeDuc is her name comes to mind. White Earth Land Recovery Project. So White Earth is the reservation that when they've recovered lands illegally that belong to the tribe, they've put those lands into food production. They've also paid for traditional harvesters of the wild rice, people that harvest the maple syrup, put it back into production, their traditional varieties of corn. So, I mean, that's a model program. But everywhere, pick a tribe, and every tribe is somehow engaged in food sovereignty. And it just depends, because the opening slide where it showed geographic regions, how tribes share a common foodway. So on the coast, you've got the salmon and, you know, different food sources. In the Southwest, you have, I think, the Gila River have also, the Pima have done amazing things getting their cactus buds and their tepary beans. And so pretty much everywhere there's stories, but it's those foods that are essential for restoring their health, just like for us, buffalo is an essential food in our soups. So I think if you can tap into the cultural foodway of a region, whether it's the Norwegians up in North Dakota, you know, or whatever, but if you can tap into that, there's something there. So.
If I might add, Gordon, there is the Alaska Health Federation. Under the Farm Bill in 2014, there was a requirement.
Is your mic on, Jean?
Maybe I didn't turn it on. Oh, there it is. Under the Farm Bill in 2014, there was a requirement that was allowing traditional foods to be used in senior programs, assisted living, nursing homes, schools, et cetera, on tribal reservations and in the villages in Alaska. And the Alaska Health Federation is developing a model program that includes that, working with their public health, they have traditional hunters, et cetera, serving it in nursing homes. And there was working with their public health and their nursing homes, and there was a traditional foods conference in Albuquerque like last week or 2 weeks ago or something like that, that dealt with this in Indian country across the nation.
Well, I'm just thinking this probably applies to the Deep South and collard greens and everything else we've been talking about. We have a lot to share.
Who's someone in that?
Nadine.
Yes, thank you for the great presentations. I have two questions. One is, two of the presenters mentioned something about needing to do more screening. And so we're talking here about a screening tool. Are we talking about measuring malnutrition, measuring food insecurity, measuring other things? Do we need a new tool, or is one of the existing tool acceptable? I think you mentioned that M&A was used, and I was just wondering what you all thought in terms of a screening tool that is needed. And the second question was for Bob. You mentioned the budget, and it's great to find out that there is some additional funding for the home-delivered meal program and congregate meal, I think. But I was wondering, I just overheard it, so I don't know, and needed clarification. Is it that they, is there also a cut in Social Security and in the Medicare? Is that going to have an increase in the need for more of these other programs? I was just wondering.
Okay, well, can you hear me? Or I need, okay, let me tackle the budget question quickly because it's still information. Let me qualify. The increase that was provided for home delivered meals and congregate meals was in a prior appropriation bill, $47 million, that came about the last time they had a budget agreement, which provided the window of opportunity. If this budget is passed, $40 billion in additional funding for non-defense discretionary programs will be available over the next 2 years. And so from there, you go into the appropriations committees and try to get the funding levels raised. So the president has put forward a budget, for example, for nutrition programs that would increase the funding by $60 million. And our organization, Ellie's organization, the Academy, other folks will go advocate, get the highest level possible, but you couldn't do that if they didn't pass this budget lifting the caps. Okay, so that's part one. On the Social Security side, the major change in the budget so far has to do with the disability insurance program to protect it from going into a negative financial situation. But the thing most seniors were concerned about was about 30% of older adults were going to face a 52% increase in their Part B premium on January 1st. Dual eligibles, very wealthy Medicare folks, and those who are on Medicare but not Social Security. This agreement will not make that happen. That increase will not happen. Older people are going to pay more for Part B premium, but nowhere near as high as what was projected to happen in January. So this agreement covers both those areas. And on the tool.
Yeah, I'll start with the tool. So I think it depends on what it is that we're measuring. If we're looking at nutrition or risk for malnutrition, I think we need a new tool. Not that we need a new tool for on admission, but there's a lot of social and economic issues that we have to take into consideration when we get ready to send people home from the hospital. So I think our tools need to be revamped or maybe enhanced a bit to make sure that we incorporate a more holistic approach to screening upon discharge.
The tool that I shared was the MiniMed. If you just Google MiniMed Nutrition Screen by Nestle, that's the tool that I shared. It's just I don't know, 8 questions. It's really basic, but it identifies the level of nutrition risk.
And there's work being done on other tools, I think, but I don't have all the particulars.
So thank you very much to our panel this afternoon. Thank you for hanging in there. It's chock full of information, and as we heard, the more educated we are, the more likely we'll have a successful aging, right? So very worthwhile staying through the afternoon. So thank you.
Thank you.